My name is Cindy Beasley, and I am the Director of Education and Advocacy for the Lamb Foundation. And it is my pleasure to welcome you to what has become a popular annual multi-regional Lamb educational meeting. This is the fifth year that the Lamb Foundation's Lamb Liaison from Minnesota, Sharon Hovland, has hosted this meeting. Its exponential growth is thanks to her incredible work in planning and leading this endeavor. Sharon was diagnosed with Lamb in 2012 and has served as a Lamb liaison for 10 years, reaching out to the Lamb community in her region and beyond. She even recently shared her planning expertise with our Lamb Liaison Network, multiplying the good work that she does. Sharon works full-time as a program manager for a global technology company and exemplifies the best of living with Lamb, both in self-care and compassionate service. So thank you, Sharon, for all that you do and for bringing us together again for this event. I am pleased to say that joining us on this call today are women living with Lamb, those who support women with Lamb, our incredibly dedicated Lamb Clinic directors from the Mayo Clinic, Loyola University, and the University of Cincinnati, as well as Lamb liaisons from across the country. And in addition, we have members from the Lamb Foundation staff with us today. We have our Development and Communications Director, Ronnie Burke, our Finance Director, Jenny Jostworth, and our Administrative and Data Coordinator, Julie Wogenstall. So I have a few housekeeping items to begin with, and we'll then turn this over to Sharon. First of all, the session is being recorded and will be available on our website in about a week or so. Secondly, the microphones should all be muted. We may have to go in and mute them on our own. Hopefully you all will do that for us. And the chat box will be disabled during the Q&A panel. Now, just slightly prior to the end of the Q&A panel, we will open up the chat box and allow you to submit any additional questions that will be answered time permitting. So it is now my pleasure to turn this session over to Sharon.
Great. Thank you so much for kicking it off, Cindy. And I also want to make sure that we thank everyone at the Lamb Foundation that's been working the past few months to help organize this meeting and make it possible today. We really appreciate everything that your team. As Cindy mentioned, we have three of our highly respected Lamb Clinic directors with us today. First, Dr. Misbah Bakir helped us introduce this Q&A session back in 2020 when we were all in lockdown with COVID, and she's stuck with us as we've rolled it out to multiple regions. Dr. Bakir was born in Saudi Arabia, but she was raised, educated, and attended medical school in Pakistan. She came to the US in 2002 and did a residency in internal medicine in Philadelphia. She then moved to Denver, Colorado, where she was a hospitalist and did bench research at National Jewish Hospital. In 2009, she started a fellowship in pulmonary and critical care at Emory University, Atlanta. In 2012, she did a one-year fellowship in interstitial lung diseases and vasculitis at Mayo Clinic in Rochester, Minnesota, where she joined the faculty the next year. She is currently an assistant professor, director of the Lamb Clinic, and program director of the Interstitial Lung Disease and Vasculitis Fellowship at Mayo Clinic. Dr. Dilling is also a veteran of this meeting. This is his third year joining us. He is a professor of medicine at Loyola University, Chicago Stritch School of Medicine, and is the medical director of the lung transplantation program at Loyola. Since 2010, he has served as director of the Lamb Clinic at Loyola, where he now cares for over 100 individuals living with Lamb. Dr. Dilling is a board member of the Lamb Foundation and also serves as medical director for the Foundation's Circle of Hope Transplant Support Program. And finally, the newest member of our panel is Dr. Nishant Gupta. Dr. Gupta is an associate professor in the Division of Pulmonary, Critical Care, and Sleep Medicine at University of Cincinnati, where he serves as the director of the Interstitial and Rare Lung Diseases Program. Dr. Gupta's clinical and research focus is in the field of rare lung diseases such as Lamb, and his work is aimed at better defining the natural history, improving detection, and developing novel treatment modalities and monitoring strategies for patients with Lamb and other rare lung diseases. Welcome, doctors, and thank you for joining us today and for all the work you've done to prepare for this meeting. Just a heads up, Dr. Gupta has to drop about 30 minutes early, and Dr. Dilling is on vacation in Germany, so he's going to drop a bit early as well. So we're trying to shuffle some questions here so we can get as much of their insight as possible before they need to leave. Okay, so let's start with the first question. Dr. Gupta, are there any new findings from the latest Lamb studies that provide hopeful results for either new medications or a cure?
I think some of you Well, the short answer is there are several. Uh, some of you likely heard uh, the newer mTOR inhibitors, if you will, at the Lamposium in your living room, presented by Drs. Krimskaya and Kotloff early in March, which are sort of looking at more completely blocking the central abnormal pathway in LAM, as opposed to the uh, less than complete blockade given by sirolimus alone. Those compounds are currently in early phase testing in other cancers, and if proven to be safe, certainly could LAM could be the next target. There is continued enthusiasm for the how the immune system evasion plays a role in the pathogenesis of LAM, and there are targets associated with that. There are targets associated with metabolic vulnerabilities of this axis. And last but not the least, there is still that unanswered question of whether hormonal therapy has a role to play in LAM or not, and that's something that we are working on. So suffice to say, there are a number of promising targets, and as we study LAM at a much higher resolution now with newer technologies, and especially more directly from human tissues as compared to animal models, that it gives us a lot more promise of identifying better high fidelity targets that we can go after. In fact, I'd say the lag right now is not a dearth of targets. I think we have several targets that conceivably one could go after. I think the lag or the major need, if you will, right now is think how do we test them, or how do we take them to human trials, and that's where I think we need to work on better endpoints, better biomarkers, more efficient trial designs, etc.
Okay, good. And are there any ongoing research projects that are looking for patients to participate, or any new studies coming up?
Yeah, so not necessarily looking for patients to participate, but I'm somewhat related to this question. I'll at least give an update on mild. I also heard that there may be several new patients here. So just we know that sirolimus works for LAM, but it was shown in the mild trial where patients had moderate to severe disease. And the mild trial is now testing whether early administration of sirolimus can help preserve future lung function decline. And several patients here, and everybody, and the clinic directors, everybody has contributed to this study. The study is fully enrolled, and so I'm hoping, and we will have some sort of an idea of the results here in about a year and a half from now. So that's just an update on mild. In terms of studies that patients could enroll in, there is from our side, we are conducting the menstrual variability in LAM study. So that's a study which is looking at whether the hormonal fluxes associated with the menstrual cycle are correlated with symptoms, with quality of life, and with lung function changes. And the idea being, if so, that could help us further stratify patients for inclusion in trials for hormonal therapies. We are almost done recruiting for that study, but still need premenopausal women with LAM who don't have cyclical variability. So we are trying to enroll patients who have cyclical variability and who don't. And we have enrolled everyone we need from a variability standpoint. But if there are premenopausal women, whether they are on rapamycin or not, who are not having cyclical variability, we are still interested in enrolling those. There is the MIDAS registry, which is collecting longitudinal data from LAM patients being seen in the clinic network. We are working on sort of making it more of a patient-facing model. So as that happens, I think that would be another way to contribute data towards LAM research. There are other projects that, if you go on the Lamb Foundation's website, they list ongoing trials and other projects that patients could involve themselves in. We are we are working on a trial looking at hormonal therapy in Lamb. So that is probably a few months away from launching, but of course we will notify the community and again the Lamb Foundation, etc. So stay tuned on that and keep checking the foundation website for these things.
Okay, great. And then is there any kind of cyst analysis that can be done to determine the severity of LAM in a patient based on the number and size of cysts on their CT scan? And can any kind of prediction be made on the rate of decline by analyzing the cysts?
Yeah, good question. That's something that a number of different groups have been thinking about, have worked on. Intuitively, it makes sense that, hey, we are looking at lung cysts. Can we just directly measure or quantify the lung cysts as opposed to an indirect measure such as lung function? And so, from a technique standpoint, it is not that difficult to quantify, if you will, what is the cyst burden on a CAT scan and ascribe a number to it. Why it is, there are a number of reasons it's not done routinely. One is that, yes, you can do it, but it hasn't conclusively been shown to be superior to, say, what we are currently doing in the form of lung function testing. And then there are the other practical issues of, is there one such technique that we think is better, easier, that can be uniformly applied everywhere? And the third is the element of every time we do a CAT scan, someone gets a dose of radiation. And if we say this is not necessarily superior to what we currently have, is that a reason to get radiation? Now, some folks here are likely familiar with going to NIH. So when they go to NIH, they do get a cyst score on the CAT scans. And there is certainly a lot less radiation in those CT scans. So I think as technology evolves and we are able to reduce the radiation dose of the CAT scan and find these uniform methods, I think we will get there. We are just not there yet. At the same time, we are also investigating other non-radiation methods, for example, MRI-based methods. But again, they are also limited by the fact that they're not widely available in a uniform manner yet. On a conceptual basis, if you take a step back, I think this is an important question because we need new biomarkers and endpoints that can quantify the image burden or the disease burden for use in future trials. And I think imaging-based assessments make perfect intuitive sense. So more work does need to be done on this aspect.
Very interesting. Dr. Bakir, can you summarize how Dr. Brown's program, LambFit, works? Would it be appropriate for patients that haven't exercised in a while? And do we need to have a medical exam before we join?
Yeah, thank you, Sharon. So LambFit is a program which is available for everyone, even including those people who have not exercised in a while. In the current study participants, 1/3 of Dr. Brown's study, they have not exercised in the past. So yes, it is available for everybody. So the protocol is that the interested individuals are asked to seek their medical provider and complete a pre-screening before they join the program. And this is to make sure that they have adequate supplemental oxygen supply during the exercise. Once they are enrolled in the program, they undergo a 6-minute walk test at home. And based on that, Dr. Brown and the group, they decide that what would be the target heart rate for that individual person. It is not only the target heart rate, but also the perceived shortness of breath that they experience during exercise. So this is an individualized program for all the participants. The target is that they have to do at least 30 minutes of at least moderate activity. For example, brisk walking or riding a stationary bike for most days of the week. And the other thing is that they wear this fitness tracker that help tracking all the activities that they do throughout the day. For example, somebody is doing gardening and the heart rate is elevated, or they are climbing stairs. So that fitness tracker would take into account all those things that will raise their heart rate. So that would count for that 30-minute period. Now, the other thing is that the enrollment for the initial preliminary or pilot study is complete, but for the interested individuals, there is a form on the LambFit website where they can fill in and let Dr. Brown know that you are interested, so she can enroll you in the future studies. But the initial final study, she is working on it right now.
Okay, so it's on the LambFit website, not the Lamb
Yes.
Foundation.
No,
Okay,
lambfit.org.
good to know. Okay, and then is anyone working on a more reliable oximeter for exercise that can give a reading without us needing to stop and hold our arm still?
So before I tell you some exciting news, but the first one is that the basic principle on which this oximeter works is the blood supply to the finger where the probe is put in. So if your hand is down and it is stable, there is the highest chance that the probe will pick up because the blood supply would be higher as compared to, say, for example, your hand is on your chest. You can imagine that the blood supply is not the greatest. Now, having said that, this issue has been brought up by many patients, including Dr. Brown's study patients. And currently, there are two companies which are funded by NIH. And Dr. Brown has actually, Dr. Brown's study people, the 15 women, 15 LAM patients have participated in a preliminary study, and they have convinced NIH for the grant. So these NIH granted companies, they're actually, one of them is working with Dr. Brown. So they will be sending more invites, and they will be taking more patients for participation so that they can prove that that these oximeters are better, and they can work with any position of the hand, etc. So they're working on it, and they will be enrolling patients. But right now, at the moment, we have the usual oximeters that we have to keep our hands still and down most of the time for better results. And to be very honest, oximeter companies are always working for these things because they hear it a lot of time. But when I talked to my respiratory therapist person, they told me that currently there isn't one that they can recommend that. I mean, yeah, there are variations in the qualities always, but there isn't any one that we can say that this is the one we recommend until we have more results from that NIH funded companies.
Okay, that's exciting that they're going to do some research on that. That's really good news. Okay, Dr. Dilling, I understand that when you're listed for a lung transplant, there's a process for determining how high you go on the list. Can you summarize the key items that they rank a patient on, and does having LAM help or hurt someone's placement?
Yeah, so this is a commonly asked question, especially in the last year, because the system for how this is all organized changed rather significantly 1 year ago, almost exactly 1 year ago. And just to give you some perspective on it, what used to be the case, well, a long time ago, you just had to wait in line for, whoever was on the list first got, sort of the next matching ones or whatever. But that changed a long time ago. But for a long time after that, there was a system set up that was meant to be as fair as possible to try and protect people from dying on the wait list. And so it was set up in such a way that people that were the most urgent, the most likely and maybe high risk of dying in the very near future. And a lot of those were people in the hospital, perhaps even on life support machines at the end of their lives with different diseases. Were prioritized in an extra special way. In fact, the urgency part of it was double weighted against the other major part, which was how likely is that person to be able to have a long life after the transplant? In fact, not a long life. How long were they likely to, how likely are they to be able to survive at least a year after the transplant? Like those were the two major things that were put in place to try and organize a priority for the people on the list. And you went on the list wherever your oxygen needs and test scores and disease state kind of put you. And LAM was, I would say, deprioritized somewhat in that system because it's not very common, thank God, that people are on the brink of death or in the hospital on a life support machine. It does happen in LAM, but it's not the usual way. It's a much more slow-moving disease, as many of you know, that becomes very gradually worse. And so the system, though, was looked at as a bit unfair because of the way it highly prioritized some people that might be very old, maybe not even good candidates for a transplant, but they could maybe, they're so sick that they would get prioritized. So it changed a year ago after a long sort of evaluation and planning process. And the new system, I think, is advantageous more than the old system was to women with LAM. And now what happens is there's still an urgency score that's developed based upon what disease you have and how bad it is and where you are in the pathway of your disease. But also the priority for longer survival is now how likely are you to be able to live 5 years rather than 1 year? And if you think about it a little bit, people who are younger tend to be more likely to live 5 years no matter what. I mean, no matter what disease you have, no matter what condition you're in. It's set up in a way that it's more advantageous to younger people, and the whereas before the priority for how sick you are was double weighted versus how likely you were to live, they're now equally weighted. So it really changed the dynamics of where a woman with LAM goes on the list, and there's some other ingredients that weren't there before, like if you have certain antibodies that you're sensitized against that you might have developed through childbearing, or maybe blood transfusions or something. Now those, you get some extra points if you have those kinds of antibody selection problems, and people with short stature, which more often affects women than men, but which limits the donors that you might be able to take. That's now baked into the point system as well. So there were a lot of ingredients that went into it that I think helped the LAM patients kind of be more likely to get a transplant faster. And in fact, what we saw a year ago, was there was a flurry of lung transplants for LAM shortly after the system changed, that was quite obvious. And subsequently, there haven't been as many transplants for LAM. In fact, I know of at least one researcher who's hoping for tissues from transplants of LAM that keeps asking me why there aren't any recently. And I think it has to do with sort of the list getting cleaned off of all the LAM patients that were waiting through this change in the system a year ago. So anyway, I think it was a good change.
Dylan. Dr. Gupta, back to you. We've heard from several Canadian LAM patients who struggle to find doctors that will provide care for LAM. Do you have any suggestions for them on how to best advocate to get the care that they need? Sorry, Dr.
No. So there is one designated LAM clinic in Canada, although not a designated LAM clinic. I think several people from Canada likely are aware of the group in Toronto with Dr. Thanganat who has a lot of patients. Over the years, we have also heard about other physicians in Canada who have had a critical mass of patients with LAM, some from other doctors, some from patients. In fact, I just spoke to a physician from in Hamilton last week who about 2 LAM patients that he has, and I was very impressed with that person. I think we do need to perhaps whittle these names down and think about adding more LAM clinics in Canada. And that may be a conversation that Dr. Dilling and I can have offline where we could share names, etc. So that could be worked on from the foundation side. I over the years have also been in touch with several patients from Canada. In fact, I see a couple of names here on the call. So again, you're welcome to always reach out to me directly for any questions, concerns they might have. And last but not the least, the most obvious answer here is to stay engaged with the LAM Foundation. There are several educational events and meetings and such as this. There is a ton of useful material on the website. And of course, if there are questions or concerns that come up, there is the foundation staff can direct it appropriately to get some answers and advice for you.
Great, thank you.
I just want to ask one question from Dr. Gupta. Are patients from Canada, they are eligible for NIH visits?
Yes,
Yes.
of course.
Yeah. Okay. Okay, thank you.
Great. Okay, I'm going to jump around just a little bit here because there's another one directed specifically to Dr. Dilling that I want to make sure we get in while he's here. In last year's meeting, you spoke about continuing to wear masks indoors with groups of people to protect us from COVID and encourage us to ease into being around groups of people by meeting outdoors. What are your thoughts this year? Should we continue wearing masks when we're indoors with crowds?
Well, obviously a lot changes year by year with this and with many things, but I think my overall philosophy about this is that there's no perfect solution to these kinds of advices. So you kind of have to individualize it to yourself and maybe talk with your doctor a little bit. But all in all, I'd say someone who has mild LAM and is really not on any sirolimus at all, I'd almost say that your risk of anything bad happening to you with LAM is the same as the general public and overall very, very low. And I wouldn't be very worried in general at all in that sense. If you chose to be a little more careful, there's nothing wrong with that. And like I said, there's no perfect solution to protect everyone perfectly. But I would say that things have changed a lot in that sense. Now, as for people that are more severe in their LAM or on sirolimus or both, it's still a pretty mild amount of immunosuppression. And I don't think that the risk is exceptional for bad things happening to you if you were to get LAM. I would say if we polled all the people in this audience, there would be probably 95% of the people have had COVID, and hopefully they've all had a vaccine and they might have had a very bad cold, and if it was COVID in the last year or so, and it might have been even a lingering bad cough, and those are the kinds of things that are probably the worst part of it now. So with the understanding that you might accept going through a rotten extended upper respiratory symptom cold kind of scenario, the risk is low that anything very bad is going to happen. Just to jump to another question that is tied to this, though, is about the vaccine. And the CDC has recently sort of updated some of its recommendations around this. And people that are 65 and older are recommended to have another vaccine, even if they've had one since the September update one. First of all, I think everyone should have, everyone healthy or non-healthy, everybody across the board except for very little children, should have a COVID vaccine if you haven't had one since September 12th of 2023, because an updated one came that day. And so people 65 and older at this point should get another one if it's been at least 4 months since your last one. And people that are immunosuppressed, they say, you might also consider having one if it's been more than 2 months since your last vaccine. Then you get into the question of like, how immunosuppressed are lamb patients on sirolimus? And like I said already, it's a pretty mild amount of immunosuppression, but it's technically immunosuppression, and you can justify getting another vaccine. You might want to just talk with your doctor or think long and hard about it yourself. And it's okay to get one, and it's probably okay to wait a couple extra months as well if you're somebody on sirolimus. There's no perfect answer for this either, given that, you know, this isn't exactly a profound amount of immunosuppression. And then for people that are maybe really bad in, you know, on a lot of oxygen and really severe, those people probably ought to be more careful than the majority of others, given that a really bad cold or even a mild lower respiratory infection, viral infection in the lungs, that could be a tipping point for somebody to get very sick. And so people like that might want to be extra wary, as would people maybe who have had a lung transplant and are more highly immunosuppressed.
Mhm.
I guess I'd bounce. Given that there's no perfect answer to that, that's my answer. If the other colleagues here have any added additions or maybe even pushback on any of those statements, I think that's fair enough.
No, perfect.
And Dr. Dilling, related to that, do you just want to comment on the question about people using oxygen concentrators in groups and flying, about the safety of that, since it doesn't purify the air that it pulls in?
Yeah, I've never actually, until I saw that question written to me, I never pondered the truth of that. Yeah, you don't wear a mask, you don't put a mask over your portable concentrator, so it's sucking in air from the ambient room or whatever. I wouldn't get worried about that.
Okay.
I mean, I just, you can only do what you can do.
Okay.
Basically, it doesn't push extra bacteria into with that air in the concentrator. So you are at the same risk as the person sitting next to you.
Yeah.
Okay.
So it doesn't concentrate the virus in any way.
Got it. Okay.
Concentrate the oxygen.
Good to know. Okay, Dr. Gupta, back to you. What guidance can you give lab patients that are entering menopause? Since we can't take hormones for symptom relief, what do you recommend?
Yeah, thanks, Sharon. I think there was another question about menopause and lung function. So if it's all okay with you, I'll just rope it all into one menopause spiel.
Yes.
Let's start with the lung function. So it's true that we generally say that the disease progression slows down after menopause, and the data for this is gets from when you have a cohort of patients with LAM and we study what is the natural history of lung function decline. Women who are premenopausal tend to decline faster than women who are postmenopausal. For example, when we looked at the NHLBI LAM registry data, the average rate of lung function decline was about 3 ounces per year. But when we looked at the premenopausal women, that was about more closer to 4.5 or 5 ounces a year, and the postmenopausal was more closer to about 2 ounces a year. And that's in contrast to, say, a normal natural lung function decline of 1 ounce per year. Okay. But to truly definitively say that in any given individual, there is a difference in trajectory from pre to post menopause, right? What we need to be able to say is that that same person was declining at a certain rate before they turned menopausal, and then their trajectory changed. And data to that level of nuance and detail is not available. So, but generally, I think most of us would agree that disease progression is slower after menopause than it is in premenopausal women. Now, does that then again, there is the inter-individual variabilities. For some women, that translates to the disease doesn't progress and we can safely watch, monitor, and not treat. And we certainly feel a lot more comfortable doing that in a postmenopausal patient than in a premenopausal patient. Sometimes this question gets asked, I have now become menopausal, can I stop taking sirolimus if I was on sirolimus before? And we don't have a good answer to that question. I will say that we tend to not stop sirolimus. If someone was on the drug and they were tolerating the drug well and the drug was working for their LAM, we don't generally tend to say that you should stop therapy because you've entered menopause. That is, however, a question worth at least discussing with your physicians if they think that maybe the dose needs to be reduced, etc. But again, generally, we take the stance that you still progress, even if you progress slower after menopause, and if you're tolerating treatment, we are on the side of let's just keep treating you. Okay, and on that front, we have several women who were diagnosed after menopause and were progressing, and we are treating with sirolimus, and they're responding well. Okay. Coming to the question you had asked about we can't take hormonal therapy. I think the most common symptom in the context of this question tends to be around vaginal dryness, and you could often say that the first line is non-hormonal lubricants. But if you need to use local estrogen creams, and there are several formulations on the market, it is perfectly safe to do so. Those local estrogens have very limited systemic absorption, and the blood levels of estrogen following those creams are well within the postmenopausal ranges of estrogen. So local estrogen creams are safe to use.
Okay, good to know. One more for you. Has there been any progress on a lighter, stronger, more discrete oxygen concentrator?
To the extent that we all would like, the short answer would be no. But within that, there is some progress being made. I was trying to scan the list to see if Bev Jackson is here. In that, if she was here, I think I would have just turfed this question to her, but I don't see her on here.
Yes.
A resource that I go to that I think is may be helpful for patients who are not aware is this website called runningonair.net. And that website has a very neatly compiled information about the currently available oxygen concentrators and what might be coming down the pike. So that may be a good resource for patients to be aware of. Just locally, we are internally working on a device that can give you more oxygen with the same flow rate, so a better sort of a reservoir in your nasal cannula tubing, if you will. But that is at a very early stage. The data on healthy volunteers looks very promising, but it needs to go through the next phase of testing. So yes, there is work being done, although I get it that we would want it to move faster than it currently is moving.
Yeah, we always do want it to. Okay, thank you. Dr. Dilling, Pfizer is no longer making the name brand rapamycin. Do we need to be concerned that the generic rapamycin will be discontinued as well?
I don't think that's anything to be concerned about at all. Rapamycin is an immunosuppressant used in several different solid organ transplant patients. So kidney transplant very commonly, also liver, heart, lung transplant, and probably others. So it's and lamb. It has enough uses out there that there will be a generic producer of it. I mean, I suppose there's always the possibility that some major manufacturer gets into some kind of problem and there may be difficulties getting the drug, as there would be with any drug anywhere. We've never seen that happen, thank goodness, but that's the only kind, but it's not going to go off the market at all.
Okay, good to know. Then in the past, there has been some concern over the efficacy of generic rapamycin, in particular foreign manufacturers. Is this still a concern, especially with the reports of various overseas drug manufacturers having quality lapses?
Yeah, I'm not aware of any specific quality problem or efficacy issue with any particular manufacturer. What I always tell people is that if that there may be different extra pieces in the compound, the extra components there. And so while it's the same medicine, it may affect the way it absorbs in your stomach compared to maybe a different manufacturer. So what I would say is anytime you do end up changing manufacturers, and you might be able to tell by the way the pill looks or maybe other information that you get with your prescription supply, but anytime you change manufacturers, you'd want to consider after talking with your doctor about it, you may want to consider getting a level drawn sometime a few weeks after the change, just to, I suppose, make sure that you're still in a good therapeutic range. But that'd be something to talk through with your doctor.
Okay, good suggestion. Dr. Gupta, I've been having brain fog. I've never had COVID, but I am on rapamycin. Could that be the cause?
Yeah, so I don't have a definitive answer for this question, but that is probably less likely. In fact, I'm perhaps more likely to attribute brain fog to LAM itself as opposed to the treatment of LAM. So the question here to consider for this individual is whether this was present before treatment and did it change after treatment. The other things outside a LAM that I do think about from a brain fog standpoint, which a lot of them sound this very common sense, general good health advice kind of thing, but are important, and we often don't always think about it, is just the importance of good sleep hygiene, making sure you don't have sleep apnea, proper, healthy, balanced diet, nutrition, exercise, other medications. So those tend to be often a lot more common reasons for having brain fog, and also a lot more easily perhaps controllable reasons that could make a difference.
Okay, good to know. All right, when I was diagnosed many years ago, there were sources that quoted the life expectancy of LAM patients to be about 8 years. I don't hear those numbers anymore. Has our life expectancy increased? And if so, what are the major contributing factors?
Yeah, good question, and I'm glad this is getting addressed, especially with a lot of new patients, because that often I'd often tell the new patients is when we are meeting the first time, even if you forget anything else we talk about, just remember this aspect of it. So if we take a step back, that's this phenomena is not unique to LAM. This is what you will see in every rare disease over and over again, is that when the disease is initially getting diagnosed or people don't know enough about it, you tend to get diagnosed patients who are more severe, more affected, and not patients who are perhaps milder. And so this 8 to 10 year data, for example, comes from studies done in the early to mid 90s with a small number of patients, and the same bias in that patients here in these studies were more severely affected. Now, as we know more about the disease, understand more about the disease, the awareness grows, you diagnose people at an earlier stage. It's not unusual to start see this life expectancy curve shift for the better. And that's not because something fundamentally has changed about the disease. It's just that we have now become better at diagnosing the disease earlier. So for instance, when we looked at the NHLBI registry and in the late 90s and linked it to long-term outcomes 2 decades later, the average survival of women in LAM in that registry was upwards of 25 years. And that was before sirolimus as a treatment was available. And so first and foremost, again, for the new patients is just remember that the average life survival, even without treatment, is upwards of 25 years and not 8 to 10 years. Okay. Now, there is, intuitively, you'd also think that as we are starting treatment with sirolimus, and if it is stabilizing the lung function decline, that perhaps that will further extend life expectancy. To conclusively prove that, I think we need more longer-term studies, but there is already some data from Europe and from China that suggests that there is an improvement in life expectancy in women who are on sirolimus as compared to who are not on sirolimus. Yeah. And that also feeds into the mild question of, if we start treating patients earlier, would that also further improve this? Right? Some of those answers will come over time, but right now it looks promising.
Yeah,
Well,
I usually invite patients to my retirement party when I first meet them.
That's nice. All right, Dr. Bakir, is it safe for those of us with LAM that are on rapamycin to take a drug like Ozempic for weight loss?
Yeah, it is. It is safe. There are many patients actually on sirolimus, especially in kidney transplant world, which are on these medications. There is only one issue, that if you're having GI side effects to begin with on sirolimus, then taking Ozempic might make it worse. So, but otherwise there is no drug interaction or contraindication.
Okay, good to know. And then can patients on rapamycin use products containing THC, such as oils, edibles, or drinks?
So there is not a real clinical data behind it, but there is a concern that THC can interact with sirolimus and it can increase the level of sirolimus. When I talked to our transplant pharmacist, he told me that if they take like occasional oil or edible here and there, that's okay, probably not a big issue. But if they take it regularly, like everyday thing, then we would be worried about sirolimus level. So I mean, I think sparing use is okay, but every day probably could be a problem. That is what I would say. I don't know whether Dr. Dilling would have anything to add on that, because he probably deals with it more than I do with transplant patients.
The transplant patients, we very strongly recommend against partaking in any of that. It's not just sirolimus, it's the other transplant immunosuppression and everything that can have interactions and level changes and everything. So it's just not a good idea. But I don't think I've ever been asked that by a LAM patient, but I mean, I suppose all this stuff is voluntary, so if you better not to, I suppose. But if you do want to partake, it's probably not a big deal. And maybe you'd say this, if it's really an issue of being affecting levels, it may be the kind of thing where you ought to do it very regularly or never, so that you maintain the same level. But then that gets problematic, maybe in a different way.
Okay.
Better to just stay away. I don't.
Why add one more complication?
Why, it's voluntary, isn't it?
Yeah. Okay, Dr. Bakir, one more for you. Is it safe for LAM patients on rapamycin to receive Botox injections for either cosmetic purposes or migraines?
Yeah, that is okay. There is no interaction with Botox and sirolimus.
All right. Dr. Dilling, back to you. Sneak in a couple more before you have to go here. Besides rapamycin, oxygen therapy, and lung transplants, what else is being done for LAM patient care?
Well, I'd say that there are sort of other symptoms that can be a part of this. The fatigue issue is real, and there's not exactly a cure for it. But as Dr. Gupta already discussed, the need to make sure that you take other reasons for fatigue as well as brain fog, I guess, would be making sure that you're getting adequate sleep and that your sleep hygiene is good. And if you want to know what that means, there's you can read about it, but it's, it's about setting up a bedroom and a sleep environment in a way that's conducive to good sleep. And making sure you don't have sleep apnea. Those would be other reasons to have fatigue, as might be other medicines you're on. So you may want to review your medicines to see if there are other reasons for it. And then living a healthy lifestyle in general. Exercise is good. Pulmonary rehabilitation for people with more perhaps moderate or severe lung disease would be a really strong recommendation. And making sure that you are connected well with someone that can help with psychotherapy if you have issues with anxiety or depression that might be related to dealing with your disease. Those would be important as well. So no specific other medicine or therapy per se, but just these sort of peripheral things that I've discussed.
Okay. And then are there any proven holistic approaches to or measures to prolong or lessen the onset of LAM symptoms?
Yeah, if holistic refers to vitamins and sort of non-pharmaceutical pills of various sorts, I don't believe that there is anything with proven benefit or that would, patients, I should say, that would talk about the benefits they've individually gotten from one thing or another, but nothing that would reach the point that I would be recommending it as, a standard way of trying to deal with the symptoms of LAM.
Okay. And then one more for you here. I've heard the guidelines regarding soy and breast cancer have changed. Women that have had breast cancer can now consume soy because the phytoestrogens don't encourage tumor growth. Is that the same for LAM patients?
Yeah, I should have looked this up to see what that statement is referring to as far as a recommendation in the cancer world. I don't know if that's true or not. But what I've always said and will continue to say is that phytoestrogens in soy are pretty mild, or not very significant in quantity. I mean, if you ate a whole lot of soy products, that you might be able to get to a point where it has some meaningful level, but I would never worry about eating a couple of edamame or putting soy sauce on something, or having some soy milk or here and there or something. But you just wouldn't want to indulge, I guess, to be sure. I don't know. Do the other doctors have different ideas or additional things to say about that?
I agree. The
Yeah.
amount of I'm sorry, the amount of estrogen or phytoestrogen in soy is very little. You have to consume a lot of soy to have. I think Dr. Larkin in LAM Foundation, she said that the soy has not helped with hot flushes. So that means that the amount is so less that it's not helpful. So this is another way of putting it, that the amount is very less. That is the whole point. So I would like to see what Dr. Gupta has to say.
Now, I think you covered it well. Really, nothing to add. Agreed. And really, when it comes to this, the answer really is moderation. I think, as Dan has also said.
Okay, great. Well, Dr. Dilling, I know that you do need to drop. Thank you for being with us today. Is there anything you want to add before you go that you'd like everybody to know?
I'm glad you're all here, because I think with community and with talking to each other, you can gain a lot of extra understanding and also peace of mind. So thank you for the invitation.
Yeah, thank you. Enjoy your vacation.
Thank you. Bye.
Thanks. Bye. Okay, well, now everything that we have left is Dr. Bakir. So Dr. Gupta, feel free to jump in. I know you have a little bit of time yet before you have to go. All right, so if we take rapamycin, can we use Tamiflu if we get the flu?
Yes. There is no contraindication. There is no drug interaction with Tamiflu and sirolimus.
Okay. And what is your opinion on LAM patients taking Paxlovid for COVID? Should all of us go on it immediately if we test positive? And do we need to stop taking rapamycin if we go on it?
So Paxlovid is a problem with sirolimus. It does have a drug interaction. So our transplant pharmacists, they have actually a protocol for those patients who are on sirolimus and are tested positive for COVID. There could be two scenarios. One is that a person was on sirolimus and is tested positive for COVID, and he's asking, or she is asking, that whether she should take Paxlovid. That is one scenario. The second scenario is that you've tested COVID positive and somebody is just put you on Paxlovid. So the number one scenario where somebody is asking that whether that person should take sirolimus, the answer is, sorry, to take Paxlovid, the answer is no. And the reason is that sometimes the interaction is bad to the point that the level of sirolimus can reach to hundreds. So that is why there are two other options that they should think about. One is this drug called sotrovimab, which is an infusion, SOTROVIMAB. Sotrovimab, or they can take remdesivir, which is again IV on day 1, followed by, and this again IV in the next 2 to 3 days. But these two options should be considered before they will think about Paxlovid. Now, if somebody is already started on Paxlovid by the local provider, or they had in their hand and they took it, at that time they have to stop immediately sirolimus and check the level of sirolimus. As I said, that level can go very high. They have to check potassium, have EKG done, and check serum creatinine and CBC, and they have to check the levels periodically after taking Paxlovid. So the short answer is, and also they look for signs of toxicity of sirolimus, which could include severe headache or tremors, confusion, visual disturbances, heart palpitations, significant changes in blood pressure, diarrhea, changes in urine output, oral ulcers, or frothy urine. That is in the case that you have taken it and now you are worried that what will happen to the levels. So you can also monitor these signs and symptoms of toxicity of sirolimus. But the short answer is that you should not take Paxlovid if tested positive.
Okay, good to know. Then the next question is, should all LAM patients get vaccinated for RSV or just those over a certain age?
So this is approved. There are two vaccines approved for RSV for ages above 60. The recommendations are, it's not like you have to take it, but I think if you have lung disease and you are on sirolimus, it is recommended that you should strongly consider it if you are above 60. And if you are pregnant by any chance, from week 32 to 36, especially in RSV, when RSV is going around, it is recommended that you take those vaccinations. So right now we are, the guidelines that we created recently, for the LAM patients, we have decided that we will put it as strongly considered, above 60 years of age.
Okay, all right. And then should all patients receive pneumonia vaccines no matter what their age are? And if so, which ones should they get?
That is a little bit tricky and long answer, because the answer is that anybody who has lung disease, for example, asthma, COPD, whatever, they should be taking the pneumonia vaccine. Now, if you go into nitty-gritty details, that what type, etc., so it's divided into this, that if you have ages between 19 and 64, or you have above 65 and like 65 and older. So those who are 19 and 64 and have never received any pneumonia vaccine, they will go with PCV20 vaccine. On the other hand, if they have previously taken PSV23 or PCV13, then they will take PCV20 1 year after the previous vaccination. And the third scenario is that they have received both 23 and 13 before. They will still take the PCV20 vaccine, but that will be 5 years after the last vaccination. So it's a little bit tricky, and it's hard to remember in that sense. So I would suggest to talk to the doctor, but the answer is that yes, and there are certain nuances about this type of strain depending on what you have received in the past and what you have not received, and depending on your age. Now, if you are 65 and older and you have never received pneumonia vaccine, then again, the first vaccine you will take is PCV20. And if you have taken PCV20 before the age of 65, then you don't need any additional vaccination. You are done. If you have taken 23 or 13 before, then you are eligible for 20, and you will take it 1 year after the last vaccination. If you have taken 23 and 13 before the age of 65, you again are eligible for 20, but 5 years after the last vaccination. So it's easy for me to tell you like that, but it might be confusing for the patients. So I would
But
say that
there-
consult your doctor.
Guidelines, there is that list of guidelines out on the Lamb Foundation site, right?
I don't know whether they have put it, but we have
Yeah.
we have finalized something, but I'm Nishant, do you know if we have put it on the website?
It should be. I'll let the Lamb Foundation staff answer it. We have created a white paper for vaccinations that should be accessible.
Yes, if you're referring to the work that was done last fall, that is all on the website now.
Yeah, that was last fall that we worked on it. So it should be there. You can, and there are many more vaccination and questions regarding that on that document, so you can look at that.
Okay. When we send out the follow-up information, Cindy, we can include that in there. We'll make sure that gets added. Okay. One final pre-submitted question, and then we'll go to the chat box. Should we stop taking rapamycin before getting any particular vaccines?
No, there is no need to stop rapamycin.
Okay. All right, great. Well, first question then, what advice would you give to a patient with mild stable lamb who is considering pregnancy?
I typically deal with pregnancy like I just give the information that what do we have, what data do we have from registry studies, and there is a high risk of pneumothoraces. There's a high risk of if you have AML in the kidney angiomyolipoma, there is a risk that will grow. There is also a risk of worsening lung functions. There is also a risk of abortion. So there is data behind it. I just give that information. On the other hand, I never say that you cannot have children. That is their decision, but the decision should be with this information that there is a chance that the lung functions can decline and the disease can get worse. On the other hand, we have so many ladies who have delivered children without much complication. So it's an individual choice. And I will like Dr. Gupta to add to it.
Yeah, thanks, Ms. Pa. That is, at least in my mind, the most difficult question we get asked about lamb is the pregnancy scenario. And it's made difficult because of, and you've highlighted it well, there is just so much variability in some people do well and others progress. But we don't have a way of identifying who is going to do well versus who is not. And that's what makes answering this question so difficult. Intuitively stands to reason that if you are starting off with milder disease with much more normal lung function, that you have higher reserve to tolerate pregnancy as opposed to someone with moderate to severe lung disease. So yes, I think that baseline where you're starting from needs to be taken into account. If we have any information about what your trajectory has been, I think that's important information to keep into account. And then there is the wild card of could you use sirolimus during pregnancy to keep disease progression at bay? That is another major question that needs to be thought about. And sirolimus is a FDA category C drug. So for the patients, what that means is, we know certain drugs are bad. We categorize them X. That is, you can't take them in pregnancy. Certain drugs we know are safe. They get categorized as A. We know there is no issue. Take them during pregnancy. C is right in the middle in that we don't know whether it is completely safe. We don't know if it's harmful. There are 2 published reports where a patient with LAM has had 2 pregnancies while being on sirolimus and done well. There are a couple other instances of this in the TSC world. There are a handful of reports suggesting overall safety of this approach in the transplant literature. In fact, we are currently working on compiling this data or the experience of women with LAM who have had sirolimus during pregnancy to better answer this question for the future, and MISPA is a part of that collection as well. So hopefully that helps us better answer this question. At the current time point, I don't think we have enough to say that everyone should or shouldn't go on sirolimus during pregnancy, but as you're contemplating this, I think it's good to have this discussion upfront with your LAM physician and your maternal and fetal medicine folks, so that if disease starts to progress, is this something that you're going to go to or not? And what are the thresholds that are going to make that answer for you? And I think having that answer thought about beforehand makes a lot more sense than trying to do this in the middle of a pregnancy when this hasn't otherwise been thought about.
Sure, good answers. Okay, next question is it okay to take Vegefem, I think it's called, for dryness?
It is one of the approved medications.
It is, okay. With sirolimus as well?
Yeah.
No difference, okay. Okay, has the origin of LAM been found yet? And have there been studies to see if there are coexisting cancers, et cetera, that are higher in LAM patients than normal populations? If so, should LAM patients be checked for other diseases?
Are these free for all questions? If so, I'm happy to take.
For all, you guys jump in, yes.
So as far as the origin of LAM, I'm assuming this question is more geared towards the source of where the LAM cells arise, right? So taking a step back, we know LAM cells start somewhere. They don't start in the lung, and then they end up sort of making a home in the lungs. And that's been a question that has vexed us for years. There is, although not fully conclusive, but we do have some data from recently done studies that suggest that uterus might be a source of these LAM cells, and that has been speculated for a long time before. And this is not conclusive, but right now I would say, if you ask me what is the leading candidate for the source of origin, I'd say it's the uterus. Regarding the coexisting cancers, there has, over the years, there has been this assertion that perhaps there is a higher incidence of breast cancer in women with LAM. But those studies had fundamental flaws in them. And so at this point in time, in my mind, there is no good evidence that suggests that there is a higher risk of other cancers, including breast cancer, in women with LAM.
Okay, good to know. Do you know whether there is a drug interaction between Taltz and sirolimus? My skin was nearly clear and my psoriasis has worsened since I started sirolimus.
Sirolimus and what?
Taltz, T-A-L-T-Z.
What's that? I don't know.
It's one of the new psoriasis medications.
Okay.
I think you should ask your physician to do. It's quick, easy to do an interaction check. I'm not familiar with an interaction between Taltz and sirolimus, but that's at least my at the top of the head information.
Yeah, the pharmacist can do the interaction check for you. So you can either ask your physician, or if you know a pharmacist, like go to a pharmacy and they can check for you. So it's easy to do it.
Okay. Is CRISPR gene therapy something we will see in this lifetime for LAM patients?
In a lifetime, maybe. It's not prime time for LAM at this point in time. Gene therapy obviously has a lot of potential, but it will likely need to start at the more obvious, easily identifiable targets. For example, things like sickle cell disease. We, for example, if you take a step back at the question, not knowing the exact origin of lamb cells, right? We need to be able to identify the source of origin and be able to correct this at that level. And that is, we are nowhere near close to that yet.
And plus the mutation in the sporadic lamb, it's not in all the cells in the body. So with the gene therapy, when we think about are those which are the mutations happen while in the fetus or before the birth. So that is more promising rather than sporadic diseases where mutation happened after somewhere in your life and not all the cells are affected by that mutation. So I would say that it might theoretically seem promising, but in theory, it might not be as easy as it sounds.
And Dr. Dilling spoke about this last year too.
Yes, I think he did. Yeah.
Try to go back and find that clip of video. I think I have the list of timing.
I think he and Dr. Adrian.
Yeah.
Yeah, he did it. Yeah.
They had a conversation about it. So, Cindy, if you can add that to my list of to-dos. Sorry. Thank you. All right. Would getting a hysterectomy be recommended for those that are premenopausal?
That is purely for lamb control.
I'm guessing that's what that's referring to. Yeah.
That is not recommended. I don't know.
Yeah, and I'd say the same at this point in time. I think we need to do proper controlled trials of hormonal therapy to find if there is any benefit in that approach before we recommend invasive procedures like that.
Okay. Then there's a second question about should a hysterectomy be considered once childbearing is not a factor if the cells may come from the uterus, or is it too late once the cells are in the lungs?
Again,
yeah,
you go ahead.
Same. I think we need to, I think we are jumping the gun here. I think we need to, as a field, first answer definitively whether there is benefit or a role of hormonal therapy in lamb or not. And we are working on trying to answer that, but that answer is not currently available. In the absence of that answer, it is difficult for me to say that someone should have an invasive procedure with its associated risks. There are other ways of also inducing menopause without having to take the uterus out, for example. So I think we should gather the data first before we make that recommendation.
Good suggestion. Are there any new discoveries or studies using stem cells and lamb? I think we could just add and lamb on the end of all of these.
I'm not aware.
No, Dr.
No.
Gupta, either. Okay. What about adding, and I can never say this, is it resveratrol in addition to sirolimus?
Yeah, Dr. Gupta can answer that question.
Yeah, I guess that question is for me.
Yeah.
So resveratrol is this sort of one of the magical compounds in red wine, if you will. For the record, don't start drinking bottles of red wine. It's the so there was some evidence in the lab that suggested that adding resveratrol to sirolimus led to more effective killing of lamb cells, on the basis of which we conducted a small trial where we gave escalating doses of resveratrol to patients with lamb who were already on sirolimus. While there were a couple of patients where we felt there was some benefit in the overall quality of life, on average, I'd say that the results of the study were negative. We didn't see any magic signal in terms of a significant drop in VEGF-D or a significant increase in lung function. So at this point, at least based on that data, I'd say there is no need to do this on a routine basis.
Okay. Good to know. I'm currently on 4 milligrams of sirolimus based on my blood tests. Is it safe to stay on 4 milligrams for many years?
Are you having side effects from sirolimus? That is another question. Are you tolerating it? 4 milligram is a big dose, in my opinion. I keep my patients either on 1 milligram or 2 milligram. I have never given 4 milligram. Have you, Nishant?
Very rarely. In general, yes, our doses tend to be similar in 1 to 2 milligrams. But I'm assuming that the dose was increased, or I'm hoping that it was based on trough levels, and the dose was raised higher because the trough levels were not within range. So if so, it probably is okay. I think the answer really lies in the blood trough level rather than focusing on a particular dose number, if you will. For example, if we look at the MILES trial, which showed the efficacy of sirolimus, the average trough level was about 7 nanograms per mil. And we hardly ever have to increase the level beyond 10 to effectively control disease. In fact, for a lot of women, very low levels, even 2, 3,
Yeah.
are sufficient to control
Yeah.
disease.
Yeah, because I think too the follow-up study after miles that say that 1 milligram was equally good as 2, that there the trough levels were not high. They were like 2 or 3, and the disease was under control.
Yeah, so I think the answer really is to just take a look at the trough levels, and if they are on the higher end, then I think reducing the dose makes sense. If they are otherwise in this therapeutic range, you're okay. We have data now from both published in terms of the long-term aspect of this question, and also from the MIDAS data that we are currently looking at least over a 6 to 7 year time frame. The treatment appears to be safe and durably effective.
Okay. What should we do if we are allergic to both sirolimus and everolimus? I have developed both bad hand and foot rashes where there are pustules and the skin peels off.
I would consider going to allergy and immunology and getting desensitized. There is usually a protocol, like they introduce these drugs slowly, very slowly over some weeks, and they slowly increase the dose and see whether you develop any reaction. So then after some time, they give you the full dose. So that is something that I will consider if you are having any strong allergic reaction to the drugs.
Good. Okay, this is another question about monitoring oxygen levels and may just reference back to what we talked to earlier. I am not on oxygen full-time, but I am supposed to wear it if exerting. I have tried different smartwatches to try to catch this. I have a pulse ox for my finger, but it doesn't alert me if oxygen levels drop. Is there a way to better monitor this?
Other than pulse oximeter? Or the question is that whether they should be alerted?
I think they're hoping to be alerted if their oxygen level drops below 90.
I am not aware of like alert. I mean, I don't know. Dr. Gupta, are you aware of it? Like,
I'm sorry, I started scrolling down the chat box and lost attention. So this is
so the question is that when the oxygen goes down, is there any way that the patient can get an alert that the oxygen is down?
yeah, good question. I'm not aware of an easy way to do this. We obviously can't keep a pulse oximeter on all day. I mean, yeah, I suppose an Apple Watch, etc., could be one way of doing it, but then you wonder about the accuracy of that approach, especially with exertion.
The watches are not accurate at all. Yeah, I don't know about any alert system. Maybe that would be a question for Dr. Brown, and I can ask her and get back to you. She would know better than anybody else. She deals with exercise in LAM patients. As I told you, they're working on a better oximeter. They might be working on some alert system too, but I will ask her. That is a separate question other than oximeter.
Yeah. Yeah, if she has any input, let us know and we'll send it out with the follow-up information.
I will.
Okay, thank you. I am an avid runner and used to be a MTB racer. Prior to my diagnosis, I would occasionally cough blood after coughing fits after tough runs or bikes. Can cyst rupture without a pneumothorax? Was the symptom of coughing blood a cyst rupture?
Yeah, well, maybe I can take a stab at it. So these are actually two separate questions in terms of, can the cysts rupture without pneumothorax? Yes, at least we think they can, right? For a cyst to rupture and a pneumothorax to happen, it has to take a layer of the lung lining with it. And that doesn't always happen. So yes, cysts can rupture without a pneumothorax. In fact, at least I think that is what in some patients explains these sort of periodic episodic chest pains that we otherwise don't have a good explanation for. And there's the second aspect of this, which is the coughing up blood with exercise. That's something that we hear from patients with LAM, thankfully not very commonly, but not infrequently. Another instance, for example, that we are currently studying is this coughing up blood after sexual activity. And we just did a survey of a few hundred women in the US and some in Brazil, and about 10% of the women endorsed this symptom. So again, not very common, but certainly can happen. And as one could imagine, the psychological effect would be distressing. The exact mechanism is not known, but we don't think it's cyst rupture. We think it is more likely related to high pressure in the blood circulation system, and that is what is causing this symptom.
Okay. How long after having COVID do we have to wait before we get a vaccine?
Is it the patient is on, if the patient is on sirolimus, it's 2 months. Otherwise, if you're not immunocompromised and you took your last vaccine in September, then you can take it in February or spring this year.
Okay, try to squeeze one more in before Dr. Gupta has to drop here. So back to Ozempic agonists. A number of my patients get recurrent vaginal yeast infections. I'm putting them on fluconazole for 6 months and sometimes longer with good results. LAM patients on sirolimus get this side effect. Is it a good plan for them, or should they discontinue Ozempic?
Ozempic should actually decrease because it controls your blood sugar, so it should decrease the chance of yeast infection rather than increasing it, in my opinion. I don't know whether it has a known side effect. It shouldn't be. Maybe I'm not well aware of it.
Yeah, I don't know. And I also worry about the fluconazole and its interaction with sirolimus.
Yes. Yes.
So if you go on this strategy, I think we need to make sure we are monitoring sirolimus levels and making sure that we are not adversely affecting that.
Yeah, I would probably consider topical rather than. Is it like a vaginal infection or UTIs?
She doesn't say specifically. Vaginal yeast infections?
Vaginal yeast infection. Okay. Yeah, I would be, if somebody's on sirolimus, then I would be worried about the levels with fluconazole.
Okay. All right. Maybe we can get one more in before you go. What are the nutrition recommendations concerning phytoestrogens?
I think Dan covered it well already. There is no major risk of underlying disease progression with dietary estrogen intake that I'm aware of, and so I don't typically ask people to modify their diet except for the message of just don't do it on a daily basis. As long as you're taking phytoestrogens in your normal diet in moderation, I think that's okay.
All right. Well, Dr. Gupta, I know you need to drop. We'll give you a minute to get over to your next meeting. Thank you so much for joining. Dr. Bakir, you want to stay on and get through a few things here?
Yep. Mm-hmm.
All right.
Yeah. Thanks, Sharon. Thanks, everyone.
Thank you. Bye-bye.
The weekend.
Thank you.
Bye.
Okay, and then there's a comment from someone about that maybe you want to pass this on to Dr. Brown too. I wish the pulse ox people would talk to the wearable glucometer people and we'd be in business. That's $1 million idea.
Yeah, the question again is that it's not reliable. It is depending on the blood supply. So that's why you have to keep it constant. But you can make a product like that, like a glucometer, but how reliable it is, that is a question. But maybe if you participate with Dr. Brown's study, you will get the answer to that. I will get back to you regarding fluconazole and Ozempic. I might have to talk to somebody. I'm not 100% sure that if it increases the risk, then what do people do? So I will get back to you regarding that too.
Okay. All right. How does sirolimus work, Dr. Bakir?
So basically, we think that if you look at the mTOR, there's a mutation in the genes that cause the mTOR is a pathway which is inhibitory pathway. It controls the growth of the tumor cells. So basically, when there is mutation in mTOR pathway, that inhibitory effect is gone. So now there is the cell is out of the inhibitory effect is gone and the cells just are growing because there is nothing to check the growth. So therefore they increase in size, they move, they survive. So that is where the mTOR pathway is working. So sirolimus is acting on that mTOR pathway to control the uncontrolled effect of the mutation. So therefore, it blocks the pathway of mTOR so that the cells are not now growing and going out of whack. So that is what the mechanism of action of sirolimus is.
Okay. I'm not sure I understand this one, but maybe you do. Oops. Is there a study to show pre-ABS post-TELC pluridesis lung function, not due to sirolimus or LAM?
So the question is, after the talc pluridesis, what happens to the lung functions? Is that the question?
I guess. Is there a study to show pre-ABS post-TELC pluridesis lung function, not due to sirolimus or LAM?
Well, I think the question is that what happens to the lung functions after the pluridesis? I don't think so. There is a study, but there could be some decline in lung functions after pluridesis because it does. It's not like significant effect, but it can cause some restriction. Not worsening in obstruction, which is usually what happens in LAM patients. But you can imagine that if you have one portion of the lung stuck to the pleural lining, it may have some effect when you take deep breath in. It might have some effect in opening up as wide as possible, but I cannot see that it will be a significant impact on lung functions.
Okay. Thank you. And then, is there any evidence for sirolimus use in patients with mild LAM and normal lung function with little or no lung function decline?
The MILD trial, the MILED, that trial will answer that question. And the results would be available after June of 2025, or they will start analyzing after June of 2025.
Okay, I just want to say thank you to everyone for joining today and giving up part of your Saturday to come learn with our great doctors, and Dr. Bakir for being the trooper that stuck it out to the end.
Absolutely.
My
I echo
pleasure.
that. Yes, I echo the thanks. I am always so impressed and thankful for our dedicated and committed LAM clinic directors. You all go above and beyond for us. So thank you, Dr. Bakir. And of course, we will personally thank Dr. Dilling and Dr. Gupta as well. And of course,
hide when my emails come through.
it's always amazing. We are so fortunate, so fortunate.
Dr. Bakir,
So, and thank
hide because she's my doctor.
It comes handy.
Well, and thank you too, Sharon, for all the work you did and that you continue to do to make sure that our LAM patient voices are cared for and heard. We are really grateful for you and for our doctors that participated and others as well. So round of applause. I know we can't really hear that, but round of applause for you all. So in closing, I want to share with everyone some upcoming events. On April 10th, we will have a Circle of Hope presentation, and this will be on lamb tissue donation. So whether you're someone who's looking at lung transplantation or have just thought about this, or maybe you're having a surgery where tissue might be available, we invite you to come and learn the who, what, when, why, and how of tissue donation. And you can register for this event on our website. In addition, and this time it'll be on a Thursday on June 20th, we will have our next Lamposium in Your Living Room webinar, where we will be tackling how to understand and interpret those mysterious CT scans that we all get and wonder about. So stay tuned for more information about that. And I know there were quite a few questions today too about sirolimus. There is a wonderful webinar we just did. It was a Lamposium in Your Living Room that Dr. Kotloff shared and Dr. Vera Krimskaya. And that is also on our webinar if you want more information about rapamycin, about its mechanism, its efficacy, and side effects. So I highly encourage you to view that if you haven't already. So as always, the Lamb Foundation is here to serve, and we thank you for the opportunity to be with you all today. So have a wonderful weekend.
Thank you, Cindy.
Thank you.
Bye, everybody.